Hi everybody, this is Dr.Manikanta, completed MD General Medicine from Kakti Medical College Varangal and currently doing DM Gastroenterology, and I secured a rank of 9 in AIMS exam Gastroenterology. So I am doing an Nephro series. In this today I am dealing with the approach to RTA. Let's begin the session. RTA, renal tubular acidosis from basic approach. Okay, so in front we have our case. So we go by case to case, right? So, a 35-year-old female came with the complaint of sudden onset SOB. Okay, she came with a sudden onset SOB to ER since 1 day, and it is a grade 4, and there is no orthopnea, PND, chest pain, pedal edema, fever, cough. That means there is no RS component and there is no CVS component of SOB. So, the SOB is due to other than RS and the CVS component, right? So, it could be due to RS. We know SOB could be due to RS, CVS, metabolic, right? It could also be due to metabolic or musculoskeletal. So by this history, I can rule out there is no RS component and there is no CVS component, right? What is left is metabolic and a musculoskeletal. Musculoskeletal means diaphragmatic muscle palsy that is usually seen in amyotrophic lateral sclerosis, Guillain-Barré syndrome, etc., etc. So metabolic causes, that is metabolic acidosis, right? So since there is no such history of any uh, muscle weakness or muscle paralysis, I will think in terms of metabolic condition is probably a metabolic condition, right? So in this metabolic acidosis, it is a case of probably a case of metabolic acidosis, right? So by suspecting it, of course, I will send her electrolytes and I will send her ABG. So in this ABG, which is their metabolic acidosis? So first of all, how to approach an ABG? It is a 7.1. We know that what is a normal ABG? The normal ABG is pH is 7.35 to 7.45 is a normal pH of an ABG. If the pH is less than that of 7.35, we call it as acidosis, right? If it is more than that of 7.45, we call it as alkalosis, right? Yes. So it is a case of, since pH is less than that of 7.35, that is 7.1, it is a case of acidosis. We know that acidosis could be metabolic acidosis or it could be respiratory acidosis, right? There are two components, no? Respiratory acidosis or metabolic. So which component is it? Either the metabolic or respiratory. How do you know? How to know? Simple. Just look for the arrow marks. The pH is reduced, bicarbonate is reduced, pACid is reduced. If all on the same direction, we call it as a metabolic phenomenon. If they are in the opposite direction, suppose bicarbonate is 30, suppose like that, bicarbonate is 30 and pACid is 60. The pH is reduced, but bicarbonate is increased, pACid is increased. They are in the opposite direction to the pH. Then we call it as a respiratory phenomenon. So here we make a diagnosis of metabolic acidosis, right? It is a case of metabolic acidosis. Whenever you diagnose a metabolic acidosis, the next step is metabolic acidosis, right? It is a case of metabolic acidosis. Good. So the next is, in the metabolic acidosis, we have two types of metabolic acidosis. No? We have high anion gap metabolic acidosis and NAG. We have high anion gap metabolic acidosis and normal anion gap metabolic acidosis. How to calculate the anion gap? So to calculate the anion gap, the formula to calculate the anion gap is sodium minus chloride, sodium minus, I am very poor at writing, sodium minus chloride plus bicarbonate. This value should be 10 plus or minus 2. If it is in the range between 10 plus or minus 2, we call it as normal anion gap metabolic acidosis. If it is more than that of 12, more than that of 12, we call it as high anion gap metabolic acidosis. So in this picture, this is a case that has presented to ER. You are an intern, posted, or a medicine PG, right? And you are seeing the case, the pH is 7.1, and you know it is a case of acidosis. Then you decided that is a case of metabolic acidosis because all in the same direction. Then you should know regarding, differentiate between high anion gap metabolic acidosis, normal anion gap metabolic acidosis. For that, you calculate anion gap, right? I given already the sodium value. It is 135, chloride is 110, and bicarbonate is how much? 13. So 110 plus 13, it is around 123 minus. So it is 135 minus 110 plus 13. So it is 135 minus 123. So it is how much? It's around 7 plus 5, 12. So it is 12. That means it is a case of normal anion gap metabolic acidosis, right? Suppose if it is if the calculated anion gap was more than 12, we call it as high anion gap. What are the causes of high anion gap metabolic acidosis? High anion gap metabolic acidosis. So what are the causes of high anion gap metabolic acidosis? Right? The simple way to remember the high anion gap metabolic acidosis is cat mud piles. It is cat mud piles. Mud piles. Right? Okay. C for cyanotic congenital heart disease, aminoglycosides, theophylline, uh, metformin, uremia, diabetic ketoacidosis, phenytoin, isoniazid, lithium, ethanol, and salicylates. Okay. C for congenital heart disease. Okay. A for aminoglycoside toxicity. Aminoglycoside toxicity. T for theophylline. Theophylline. Okay. M for metformin. Metformin toxicity. U for uremia. That means CKD patients. Okay. Early stages of CKD will have normal anion gap metabolic acidosis. Advanced stages will have anion gap metabolic acidosis. Right here. Early stages will have NAG, normal anion gap metabolic acidosis. Later it becomes high anion gap metabolic acidosis in advanced stages. Okay. D for diabetic ketoacidosis. P for phenytoin or paracetamol toxicity as well. Most important one is phenytoin toxicity. I for the isoniazid, L for the lactic acidosis, E for the ethanol, and S for the salicylates. Okay, nothing an aspirin. Okay, so since here it is more 10 plus or minus 2 within the range, that is normal anion gap metabolic acidosis, all these causes are ruled out. What I am left is NAG, that is called as normal anion gap metabolic acidosis. How to approach a normal anion gap metabolic acidosis? If a patient is having normal anion gap metabolic acidosis, how do you approach? What will the causes? Acidosis. This suggestive of normal anion gap metabolic acidosis suggestive of either renal loss, either renal cause or GI cause, gastrointestinal cause. Okay. By history also we can differentiate if there is usually history of loose stools or if there is any bypass surgeries, right? Suppose a diversion procedure such as ureterosigmoidostomy, etc. In that cases, probably take a GI. I will think in terms of GI antenna. Or you can also go for what? Urinary anion gap. Okay, we can go for the urinary anion gap. Okay, how to calculate urinary anion gap is urinary sodium plus urinary potassium minus urinary chloride. Okay, this value should be 0 or negative. This is normal. If it is positive, that is suggestive of renal loss. Ante it is a case of RTA, renal tubular acidosis. Okay. If it is 0 or negative, that is suggestive of GI loss. Okay. Ante gastrointestinal causes, anything causing diarrhea, ureterosigmoidostomy. Okay. These are the examples. Suppose since I have not given a history of diarrhea, there is in the history there is no diarrhea. We'll think in terms of an RTA since it is also a female patient. Okay, which condition actually produces RTA in female? Sjogren's, no? It is a case of Sjogren's. Okay, not saying, but you have to differentiate very causes. No, now we have come to a conclusion. It is a case of metabolic acidosis. Yes, it is a case of metabolic acidosis. Under the metabolic acidosis, it is a case of normal anion gap metabolic acidosis. Under normal anion gap, it is a case of RTA. Right? Well and good. We have come to the conclusion. It is a okay. Once you made the diagnosis of RTA, the next step we have to do is the serum potassium. Okay. The next step we have to do is the serum potassium, because the classification of RTA is based on the serum potassium. If the serum potassium is low, the serum potassium could be low, that is less than that of 3.5 milliequivalents per liter, or it could be normal, that is between 3.5 to 5.5, or it could be high, that is more than that of 5.5. If it is low, that is less than or 3.5, we call it as hypokalemic RTA. This is known as hypokalemic RTA. right? If it is normal, that is 3.5 to 5.5, that is a normal serum potassium. This is known as RTA of renal impairment. RTA of renal impairment. RTA of renal impairment. If it is more than that of 5.5, that is hyperkalemic RTA. This is known as hyperkalemic RTA. Hyperkalemic RTA. That is more than the 5.5. This is hyperkalemic RTA. Which type? Type 4 RTA is known as hyperkalemic RTA. If the patient is having hypokalemic RTA, what are the examples for hypokalemic RTA? We have type 1 RTA, we have type 2 RTA, and we have type 3 RTA. Type 3 RTA is nothing but combination of type 1 versus and a type 2 RTA, that is proximal and distal. This is important only for the SS preparation. Okay. Right. Suppose in our case, right, I wantedly did not give the potassium because her serum potassium is 2.9 milliequivalents. If her serum potassium is 2.9, that means she is fitting into where? Hypokalemic RTA or RTA of renal impairment or hyperkalemic. That is 2.9 na? So she is having hypokalemia. So she is having hypokalemic RTA. That means it could be either type 1 RTA, type 2 RTA, or it could be type 3 RTA. That is a combination of type 1 and type 2 RTA. If her serum potassium was normal, we call it as RTA of renal impairment. Right, I told what CKD will have high anion metabolic acidosis, but early stages will have normal anion metabolic acidosis. This is what we call as RTA of renal impairment. If her potassium was 6.5, we call it as hyperkalemic RTA, nothing but what? Type 4 RTA. Type 4 RTA. Okay. Right. Before discussing regarding the RTA, you should know regarding the renal tubular structure and function. That is the structure and function of a nephron. So what are the different parts of a nephron? We have the glomerulus, then you have the proximal converted tubule, right? Then you have loop of Henle, then you have thin ascending limb of loop of Henle, thick ascending limb of loop of Henle, distal converted tubule, then you have collecting duct. These are the parts of nephron, right? This is glomerulus, this is PCT, this is a loop of Henle, this is DCT, this is collecting duct, right? This is a descending limb of loop of Henle, this is hairpin bend of loop of Henle, this is thin ascending limb, this is thick ascending limb, this is DCT collecting duct, right? Note, maximum solute and the solvent is reabsorbed where? Maximum solute and the solvent, maximum solute and solvent, maximum solute and the solvent is reabsorbed where? It is actually reabsorbed in proximal converted tubule, except which solute is maximally reabsorbed in the loop of Henle? It is magnesium, except magnesium, that is maximally reabsorbed in the loop of Henle. Which segment of loop of Henle? Thick segment of ascending limb of loop of Henle, it is maximally reabsorbed, right? So RT are actually renal tubular dysfunction, that is defect in the different parts of nephron. So type 1 RTA defect in which part of the nephron, type 2 RTA defect in which part of the nephron, and type 4 RTA defect in the which part of the nephron, right? Type 1 RTA is also called as distal RTA, that is defect in the collecting duct is type 1 RTA, right? It's also called as distal RTA. Okay, why it is called as type 1? Because it is first discovered, that's why it is called as type 1. Type 2 is proximal RTA, that is the defect is PCT. This is type 2 RTA, which is also called proximal RTA. Type 4 RTA is again defect in the collecting duct only. Then what is the difference between them? Remember, if the H+7 excretion defect is type 1 RTA excretion defect, whereas type 4 RTA is potassium excretion defect. Okay, potassium excretion defect I will explain in detail when compared to type 4 RTA, right? Next, we deal with differences between type 1 and type 2 RTA. We already come to conclusion that she is having RTA and her potassium is 2.9. Therefore, she is having hypokalemic RTA. So, which could be type 1, type 2 and type 3. Then how to differentiate between them, we'll learn now. Okay. So, we have type 1 RTA versus we have type 2 RTA. Type 1 RTA and type 2 RTA. What is other name for the type 1 RTA? Type 1 RTA is also known as distal RTA. Right, it is also called as distal RTA, and type 2 RTA is also known as proximal RTA. Okay, type 1 RTA is distal RTA, type 2 RTA is known as proximal RTA. Distal RTA means which part of the nephron is actually affected is the collecting duct, Type 2 is a proximal RTA, that is which part of the nephron is actually affected is PCT, proximal converted tubule. Right. What is the common features of type 1 type 2 RTA? That is till now what we discussed, both will have metabolic acidosis, right? Under the metabolic acidosis, right, both are having metabolic acidosis. Metabolic acidosis and means the pH is less than that of 7.35 and there will be low bicarbonate as well, that is less than that of 24, right? And both are having under the metabolic high anion gap normal, both will have normal anion gap metabolic acidosis, that is 10 plus or minus 2 within this range. How to calculate normal anion gap? How do you calculate anion gap? It is a sodium minus chloride plus bicarbonate, right? And both will have positive urinary anion gap, positive urinary anion gap, and both will have I will explain why there is hypercalciuria in both. Hypercalciuria will be seen in both, right? These are the common features. Still now our lady is having metabolic acidosis, normal anion metabolic acidosis, positive urinary gap, that's why we call it as RTA. If a urinary anion gap is negative, it is secondary to GI loss, right? If it is a positive, we call it as a renal loss, that is RTA. And both are having hypercalciuria, right? I told what proximal RTA is defect in the PCT, proximal converted tubule. So we have the glomerulus here, glomerulus. Here we have the proximal converted tubule. Here you have the loop of Henle, thin ascending limb, then you have thick ascending limb, then you have a DCT, then you have collecting duct. This is PCT, na, proximal converted tubule. Maximum solute is reabsorbed where? In the PCT, except magnesium. I told what? Maximum solute. It is 67% of the sodium, 67% of the potassium, chloride, calcium, and water is reabsorbed in the PCT, and 80% of the bicarbonate is reabsorbed along with phosphate. Is reabsorbed, and 100% of glucose and 100% of glucose and amino acids are reabsorbed in the PCT, except magnesium that is reabsorbed in the loop of Henle, right? So if there is a type 2 RTA, that is nothing but PCT dysfunction, that is a proximal converted tubule dysfunction, proximal RTA. So if the PCT is dysfunctional, what will happen? There will be defect in the reabsorption of sodium, potassium, chloride, calcium and water, and also bicarbonate, phosphate, glucose and amino acid. Therefore, the patient will have glucosuria, loss of glucose in the urine, glucosuria, amino aciduria. The patient will also have bicarbonate urea, and phosphaturia, right? Good. So right here, in a type 2 RTA, nothing but proximal RTA, the patient will have glucosuria, amino aciduria, glucosuria, amino aciduria, phosphaturia, glucosuria, amino aciduria, phosphaturia, and the patient will also having bicarbonate urea. Therefore, simple test to differentiate between proximal versus distal RTA, that is type 1 versus type 2. Type 2 is proximal, na? Complete urine examination we do. Okay. If the patient is having complete urine examination, glucosuria, monosodia, phosphate, bicarbonate, it is which RTA? Proximal RTA, that is type 2 RTA, right? So what is the reason for metabolic acidosis in case of type 2 RTA, proximal RTA? It is because of loss of bicarbonate, that is bicarbonate urea. I explained why there is metabolic acidosis in type 2 RTA, because of loss of bicarbonate. So my question is, normally the diabetic mellitus patient will have glucosuria. Suppose if the patient is non-diabetic and having glucosuria, what do you suspect? Proximal RTA. So where do you, this is a question, entrance question, where do you get normoglycemic glucosuria? Normoglycemic glucosuria. Where do you get normoglycemic glucosuria? It is type 2 RTA, renal tubular acidosis, nothing but proximal RTA, proximal RTA. Okay, good. Right. So why there is hypercalciuria in case of type 2 RTA? Because I told 67% of the calcium is actually reabsorbed in the PCT. That's why the patients of proximal RTA will have hypercalciuria. Correct. So next, coming to the distal RTA, that is which part is affected is a collecting duct. Will you see any glucosuria? No. Will you see any amino aciduria? No. Will you see any phosphaturia? No. Will you see any bicarbonaturia? No. Right? But both the patient will have metabolic acidosis, normal anion gap, positive anion gap, and hypercalciuria. Why there is hypercalciuria here? I told in proximal converted tubule there is reabsorption of the calcium, no? But why hypercalciuria in case of distal RTA, which is affected, is collecting duct here. So why there is hypercalciuria? Remember, whenever the patient is having metabolic acidosis, right, there will be a compensatory mechanism to buffer the acidic component. So there will be, so what is the major buffer is our bone, no? So there will be bone resorption, there will be increased bone resorption. Because of increased bone resorption, there will be release of phosphate. This neutralizes the acid, neutralizes the acid, and there is also release of calcium. This calcium is filtered by the kidneys and causes what? Hypercalciuria. Okay. Whenever the patient is having hypercalciuria, what will happen to the kidneys? There will be increased risk of formation of what? Renal stones. There will be increased risk of formation of renal stones, and there will be increased risk of nephrocalcinosis. Okay. So that is the reason. Proximal converted dysfunction will also have hypercalciuria, that is proximal RTA. Distal RTA will also have hypercalciuria. But here the patient will have increased risk of renal stones and nephrocalcinosis only in distal RTA. There will be no risk in case of proximal RTA. Why? I told whenever there is hypercalciuria, actually there is risk of renal stones and nephrocalcinosis as well. But in proximal RTA, there is no risk. Why? The reason for this is because another compensatory mechanism for metabolic acidosis is what? There will be increased citrate reabsorption. There will be increased citrate reabsorption from proximal converted tubule. Why there is increased citrate reabsorption from proximal converted tubule? The reason is because of increased citrate reabsorption, the citrate now enters the liver, which is converted to bicarbonate. Now this bicarbonate compensates acidosis, that is neutralizes the acid. So because of the increased citrate reabsorption from PCT, the patient will have hypocitriuria. Because we know that the citrate actually prevents the precipitation of the calcium salts. So if a patient is having hypocitriuria, there is no citrate, therefore there will be increased precipitation of the calcium salts, leading to renal stones and nephrocalcinosis, right? But in case of PCT dysfunctional, that is proximal RTA, what will happen to the citrate reabsorption? It is impaired. If therefore the patient with proximal RTA will have hypercitriuria. Because of hypercitriuria, it prevents the precipitation of the calcium salts. That's why there is no risk of renal stones or nephrocalcinosis. So right here, hypercalciuria, and if we talk regarding the citrate excretion, here in case of proximal RTA, the patient will have hypercitriuria, preventing the renal stones. Here the patient will have hypocitriuria, because of which there is increased risk of renal stones and nephrocalcinosis. Right. Another way of differentiating, right, the sixth point here, the urinary pH. That is, in case of proximal RTA, it is more than less than that of 5.5, that is acidic urine. But in case of distal RTA, it is more than that of 5.5, that is alkaline urine. Why alkaline urine? So if we have distal RTA and we have proximal RTA, in terms of urinary pH, right? In distal RTA, nothing but type 1 RTA, proximal is type 2 RTA. Here the urinary pH is more than 5.5, that is alkaline. Here it is less than 5.5, that is acidic urine. Okay, it is alkaline urine. Why? The reason is why alkaline urine in case of distal RTA, because if you know the function of collecting duct, this is collecting duct. Collecting duct will have P cell, I cell. I cell is also called as buffering segment of the nephron. So in the collecting duct, we have ENaC channel. This ENaC reabsorbs the sodium. Along the sodium, what also enters is water because of osmotic balance. So because ENaC channel, epithelial sodium channel, that is present on the collecting duct, it reabsorbs the sodium. What enters inside the collecting duct is sodium. So the collecting duct now becomes what? Positive charge. To maintain the electrical balance, it loses the other positive charges, that is potassium and hydrogen. Right? This occurs in where? Collecting that. Potassium excretion is via ROMK channel, and H plus ion excretion is via hydrogen ATPase channel. Okay, if there is a defect in the hydrogen ATPase channel, what will happen? H plus ion excretion is impaired. That is what type 1 RTA is. That is what type 1 RTA, nothing but a distal RTA. I told what? Distal RTA is defect in the H plus ion excretion. If there is a defect in the potassium excretion, we call it as type 4 RTA. How it causes metabolic acidosis, I will explain in the type 4 RTA. Just for now, remember this occurs in the collecting duct only. Different cells are involved. If H plus ion excretion is impaired, we call it as type 1 RTA. So if there is no H plus ion, because H plus ion excretion is impaired, there will be no H plus ions in urine. So what will happen to the urine pH? It will be increased. That is more than that of 5.5. That is called as alkaline urine. Okay, what we get is alkaline urine. But in case of proximal RTA, I told what in proximal RTA, which part of the nephron is affected is only in PCT. The distal collecting duct and the distal segment of the nephrons are intact. If the distal segment of the nephron is intact, right, it can still excrete the H plus ion. It can still excrete the H plus ion. Therefore, the urine pH is less than that of 5.5. That is acidic urine. That's why you get in proximal RTA acidic urine. Acidic urine. Right? So that's it regarding the differences between the type 1 and type 2 RTA. Both will have metabolic acidosis. What is the reason for metabolic acidosis in proximal convertible dysfunction? That is type 2 RTA, impaired bicarbonate reabsorption leading to bicarbonate urea. But in case of distal RTA, it is because of impaired H plus ion excretion. Okay, that is the reason. Both will have normal anion gap, positive urinary gap, hypercalciuria, but renal stones are seen only in distal RTA because of hypocyturia. In case of proximal RTA, the patient will have hypercyturia, that preventing the renal stones and nephrocalcinosis. Therefore, there is no renal stones and nephrocalcinosis. Citrate excretion, here there is a distal RTA hypocyturia. I also explained why there is hypocyturia. It is a compensatory mechanism for metabolic acidosis. There is increased reabsorption of citrate from the PCT, proximal converted tubule, which is now converted to bicarbonate, which neutralizes acid. But since proximal RTA, the PCT is dysfunction, the citrate reabsorption is also impaired. That's why the patient will have hypercitriuria, preventing the renal stones and nephrocalcinosis. Urinary pH is acidic, that is less than that of 5.5 in case of proximal RTA, more than that of 5.5 in distal RTA. There is a one exception for this, that is in which normally the proximal RTA will not cause any renal stones. But what is the cause of proximal RTA also leading to renal stone is a topiramate. This is an SS question. So, a cause of proximal RTA leading to renal stones. Normal in case of proximal RTA, we don't get renal stones, but there is a one cause of proximal RTA which can lead to renal stone, that is topiramate. Topiramate is a drug which can lead to proximal RTA and leads to renal stones because it causes hypocyturia. Hypocyturia. Okay, good. As so Our Lady, we came to Our Lady, right? So how to differentiate by type 1? Our Lady is having what? Our Lady is having hypokalemic RTA, na? She's having 2.9 potassium, and we came to a diagnosis of metabolic acidosis, normal anion gap, and RTA, positive urinary gap, and she's having potassium of 2.9. That is hypokalemic RTA, which could be type 1 and type 2. To differentiate between them, we should go for complete urine examination, urinary pH, and USG abdomen, pelvis. Now I should order her CV, urinary pH, and USG, because if the CV, if I see glucosuria or amino aciduria, that is proximal RTA. If there is no glucosuria, amino aciduria, it is distal RTA. And urinary pH, if it is alkaline, distal RTA. If it is acidic, it is proximal RTA. USG is showing renal stones, nephrocalcinosis, distal RTA. And if it is there is no renal stone nephrocalcinosis, it is a proximal RTA. So I will order her CV, urinary pH, and USG abdomen. Then after making the diagnosis, suppose she is not her urinary pH is more than the 5.5, and I order her CV. Her CV came as urinary pH more than that of 5.5, and there is a renal stones in USG. So straightforward, I make a diagnosis of distal RTA. So what are the causes of distal RTA? So now I should evaluate the causes of distal RTA and proximal RTA. So what are the causes? First we discussed the causes of type 1 RTA. Type 1 RTA. So what is the other name for type 1? It is not a distal RTA. Again, recap, what the patient with the distal RTA will have? Metabolic acidosis, that is which type? Normal anion gap metabolic acidosis, and the patient will have positive urinary anion gap, and the patient will have hypercalciuria, and there will be increased risk of renal stones, nephrocalcinosis, and urinary pH is more than that of 5.5, that is alkaline urine, and the patient will also have hypocituria. Okay, hypocituria. So what are the causes of distal RTA? We have inherited causes and we have acquired causes. Among the inherited causes and we have acquired causes. Inherited causes, I told what it is due to the defect in case of hydrogen ATPase defect. It is due to the defect in hydrogen H plus ion excretion, that is hydrogen ATPase defect. Hydrogen ATPase defect in collecting duct, which is usually autosomal recessive type of inheritance. Okay, there is also one autosomal dominant type of inheritance, that is anion exchanger defect on the basolateral side. Anion exchanger defect in basolateral side. Okay, so mostly it is due to hydrogen ATPase defect located on the apical side, could also be due to anion exchanger defect on the basolateral side, both in the collecting duct defect. Acquired, we have autoimmune conditions. Most important of the autoimmune condition which can lead to the distal RTA, that is type 1 RTA, is Sjogren's. Then anything causing hypercalcemia. Hypercalcemia can lead to distal RTA, that is type 1 RTA. So what are all the causes of this hypercalcemia? We already know hyperparathyroidism, vitamin D intoxication, multiple myeloma, sarcoidosis, granulomatous disorders, that is sarcoidosis, tuberculosis, lymphomas, right? Or it could be PTH-RP related hypercalcemia, that is humoral hypercalcemia of malignancy, right? Anything causing hypercalcemia, right here, hyperparathyroidism. Example is hyperparathyroidism, vitamin D intoxication, sarcoidosis, tuberculosis, lymphoma, etc. Okay. Next is tubulointerstitial causes. Tubulointerstitial causes, which includes medullary cystic kidney disease and post-transplant kidney. And we have last drugs. The drugs are important. Mnemonic for the drugs causing distal RTA is LAC, that is lithium, amphotericin, and cisplatin. It is a lithium, amphotericin, and cisplatin, including antiviral drugs. Okay, that's it regarding the causes of distal RTA. So what are the causes of proximal RTA? What is the other name for the proximal RTA? We also call it as type 2 RTA. So again, we have inherited, we have acquired. Inherited causes and we have acquired causes. Inherited causes, sodium bicarbonate. So it is usually due to the defect in case of sodium bicarbonate transporter in PCT. Proximal converter tubule, carbonic anhydrase type 2 enzyme defect. This is actually produces type 3 RTA, which is also called as Guibard-Vain cell syndrome. Guibard-Vain cell syndrome. Okay, carbonic anhydrase enzyme deficiency, sodium bicarbonate transporter defect. It could also be due to galactosemia, tyrosinemia, hereditary fructose intolerance, Wilson's disease, Lowe syndrome. Remember what is the inheritance of this Lowe syndrome? Is an X-linked inheritance, right? It is also called as oculocerebral renal syndrome. What is the renal manifestation? Is type 2 RTA. Cerebral is hypotonia, and the patient will also have mental retardation. Ocular, the patient will have cataract and glaucoma. Okay, that's a Lowe syndrome, also called as oculocerebral renal syndrome. Right, these are the inherited causes. So sodium bicarbonate exchange defect, carbonic anhydrous, galactosemia, tyrosinemia, hereditary fructose intolerance, Wilson's disease, Lowy syndrome. Right, what are the acquired causes? Remember, acquired causes, first one is multiple myeloma. Remember, multiple myeloma will lead to hypercalcemia, which can lead to distal RTA as well. But there will also be myeloma light chain excretion, which are toxic to the tubules, predominantly to the proximal converter tubule. That's why multiple myeloma predominantly to proximal RTA. Then drugs. Drugs includes, remembered, aminoglycosides. Sorry, it is aminoglycosides, tetracyclines, ifosfamide, cyclophosphamide, and tenofovir. Rest all antiviral drugs leads to distal RTA. I told you antiviral, LAC plus antiviral, except tenofovir, which lead to proximal RTA. And also write tenofovir, topiramate, and estrazolamide. These are the drugs which can lead to proximal RTA. Of course, tubular interstitial can lead to both proximal and distal, mostly to distal. That is medullary cystic kidney disease, post-transplant kidney, including the Sjogren's. So tubular interstitial, we have medullary cystic kidney disease, right? A post-transplant kidney and Sjogren's. All this will predominantly lead to distal RTA. Sometimes I can also lead to proximal RTA as well, and miscellaneous conditions. Miscellaneous including nephrotic syndrome and amyloidosis, which can also lead to distal RTA. Sorry, proximal, which leads to proximal RTA. That's it regarding the distal RTA as well as proximal RTA. The treatment, of course, we have to go for, if there is hypokalemia and metabolic acidosis. For metabolic acidosis, we go for alkali replacement, and for hypokalemia, we go for potassium replacement. In detail regarding the how to give potassium replacement, I have done it in hypokalemia section. Please watch it there. Thank you. That's it regarding the type 1 and type 2 RTA as well as approach to RTA. In detail regarding the type 4 RTA, I have dealt in the separate video along with approach with hyperkalemia, because if you know type 4 RTA, simultaneously we can finish hyperkalemia as well. Please do subscribe the channel and like the video and do comment. Thank you.